Hello, welcome to the UCSD School of Medicine ultrasound course. This is Session 3, Cardiac. Here is an overview of what we'll be discussing today. We will start with a general approach to the exam and the preparation necessary. Then we'll talk about some relevant cardiac anatomy, at which point we'll move forward into the crux of the presentation, and that is an introduction to echocardiography and how one obtains the 4 principal cardiac views. We'll close the presentation with an overview of relevant physiology and pathophysiology that seek to drive home many of the concepts that we will discuss today. When getting ready to perform the exam, you need to be certain that you select the proper transducer. An ideal transducer to perform a cardiac ultrasound will be one that has a small footprint. In other words, one that has a small point of contact with the patient. This is important because it will allow us to maneuver between the ribs. Also, you want to be certain that you have a transducer that operates at a low frequency range. This is important because it will allow us to penetrate deeper into the thorax and get optimal images of the heart. Thus, the phased array transducer is the ideal transducer to perform the cardiac exam. When you get ready to perform the exam, in addition to selecting the correct transducer, you want to be certain that you have selected a cardiac mode on the ultrasound system. This is important because it will optimize the internal settings of the machine such that you will get ideal images of the heart. In addition, there are some manual controls that you are already familiar with, including the gain and the depth, that you can adjust to your liking so that you can get the best images possible. Of course, before you actually perform the exam, always be certain to explain to the patient what you'll be doing and why you'll be doing it. Patient positioning is very important with all things ultrasound, as we've discussed in prior sessions. However, when it comes to echocardiography, it's a particularly crucial part of the exam, and I would ask you why that is. Take a moment to consider that. We'll continue this discussion a little bit later in the presentation. Give that some thought for a moment. For echocardiography, largely we'll have the patient either in the supine position or in the left lateral decubitus position. There are a couple of physics concepts that are important to think about when you're performing a cardiac ultrasound. Particularly, I'd like you to think back and remember that sound waves need a medium through which to travel. They don't like air. They like to travel through a medium such as water, fluid, blood, for example. Another thing to consider is that sound waves cannot penetrate through bone. This is also going to prove to be quite important when we think about imaging the heart. Thus, when performing cardiac ultrasound, there are some unique challenges you will encounter, and this is because the heart is surrounded by impediments to ultrasound. For the reasons we discussed previously, the aerated lungs and the thoracic cage are 2 significant impediments to ultrasound and will make the exam a bit more challenging, because again, the sound wave does not easily travel through the air, nor can it penetrate the ribs. In addition to these facts, you also have to take into consideration that the heart is a dynamic structure. Because it's moving constantly in multiple planes, that can also make imaging the heart more difficult at times. Due to these inherent thoracic anatomical challenges, proper exam preparation plays a huge role in echocardiography, and this is the point I was getting at a few minutes ago, why it's so important to position the patient properly to get ideal cardiac windows. You want to use a small footprint ultrasound probe to allow for maneuvering between the ribs, and you want to position the patient in a left lateral decubitus orientation such that the heart will be closer to the chest wall. This will allow for optimal imaging of the heart. Now let's talk about some relevant cardiac anatomy. When thinking about the heart as it sits in the chest, remember that it sits obliquely within the thorax. The base of the heart corresponds to the atria and the valves. The apex of the heart corresponds to the distal aspect of the ventricles. When we image the heart, we generally are going to image the heart in either a long axis, which would refer to a plane running from the base of the heart to the apex of the heart, or alternatively, you can think about it as a plane running from the right shoulder to the left flank of the patient. This will be imaging the heart in a long axis. We also will oftentimes image the heart in a short axis with the ultrasound beam. And a short axis is the plane running perpendicular to the long axis just described, and that is a plane running from the left shoulder of the patient to the right flank. So we have the long axis running from the patient's right shoulder to left flank, and the short axis, which is a plane running from the patient's left shoulder to the right flank. The atria, as you recall, are thin-walled, low-pressure structures. They essentially are reservoirs of blood for the right ventricle and left ventricle. The ventricles have thicker myocardium, and in particular, the left ventricle greater than the right ventricle. The contraction of the ventricles propels blood through the outflow tracts, through the pulmonary artery for the right ventricle, and through the aorta for the left ventricle. When a patient is lying supine, the right ventricle will be the most anterior cardiac chamber. It's also notably smaller than the left ventricle. The left ventricle has thicker myocardium as compared to the right, and is also approximately twice the size of the right ventricle. Now let's turn our attention to the cardiac valves. The valves, as you may recall, are thin flaps of fibrous tissue. They're covered by endothelium, and their movement is passive. In other words, there is no muscular contraction necessary for them to open or close. As the valves open and close, this is what allows for unidirectional flow of blood from the atria into the ventricles and out the respective outflow tracts. When we talk about cardiac valves, there are two types of valves. There are the atrioventricular valves, and there are the semilunar valves. Regarding the atrioventricular valves, we have the tricuspid valve, which allows blood to flow from the right atrium into the right ventricle. And we have the mitral valve, which is a bicuspid valve, and this allows for blood flow from the left atrium to the left ventricle. The overlap of leaflets in the closed position is what allows for unidirectional blood flow when the valves are functioning properly, that is. This is a dissection of a human heart, and it demonstrates some relevant anatomy that is quite easy to discern when performing echocardiography. First, I'd like you to notice the chordae tendineae, and these are small areas of tissue that connect the free edges of the atrioventricular valves to the papillary muscle. They have a very important function because they prevent eversion of the valves during systole. This properly ensures their function. Now let's focus our attention to the semilunar valves. The semilunar valves include the pulmonic valve, which allows for blood flow from the right ventricle into the pulmonary artery, and the aortic valve, which allows blood to flow from the left ventricle into the aorta. Both of these valves are composed of three cup-like cusps. Let's focus our attention now to the pericardium. The pericardium is an epithelialized fibrous sac. It covers the entirety of the heart and the cardiac portion of the great vessels. It contains a small amount of fluid as well as some epicardial fat, and this is helpful for lubrication. This sac is minimally distensible, and this is important because in the event that there is fluid within the pericardial sac, as the pressure increases, since the sac cannot stretch because of this minimal distensibility, this can lead to hemodynamic compromise due to impaired cardiac filling, and this is referred to as cardiac tamponade. Now, let's move forward and discuss an overview of echocardiography. When we talk about echocardiography, this is essentially another way to describe cardiac ultrasound, and it is commonly referred to simply as echo. It's helpful for many clinical conditions as well as procedural guidance. Specifically, it's very helpful in evaluating patients when there is concern for heart failure, evaluation of chest pain, or evaluation of undifferentiated dyspnea. It's a wonderful modality for evaluating for pericardial effusions as well as to perform pericardiocentesis, which is simply draining an abnormal pericardial fluid collection. When talking about echocardiography and learning about it as you are today, you should probably realize that there are two broad types of echocardiography. There is the transthoracic approach, otherwise referred to as TTE, transthoracic echocardiography. There is also a transesophageal approach, otherwise known as TEE, transesophageal echocardiography. Each of these techniques requires specific equipment and training. TEE is more invasive, takes longer to perform, and is beyond the scope of this presentation today. Generally, it is something that is not performed nearly as commonly as TTE, and is often performed either by cardiologists or by cardiac anesthesiologists during cardiothoracic surgeries. Today, we'll be focusing our attention on the transthoracic approach, or TTE. When discussing transthoracic echocardiography, here are some basic considerations. With this exam, there are essentially 4 primary echo views. Understand that there are many others, but we will be focusing our attention on these 4 main views today. Each of the views offers additional information that cannot necessarily be obtained from any of the other views. Each view gives a different perspective to cardiac anatomy and function, and taken in total can allow you to get more information from a scan as opposed to looking at only 1 or 2 of the views as opposed to all 4. Interpreting multiple views often yields additional data and insight and gives you a better overall idea of cardiac function. This is analogous to the illustrations of this woman's face. If, for example, I were to only show you 1 or 2 of these images and ask you what this woman looked like, it would be hard for you to do that. However, if we give you such an illustration with 4 different perspectives of the same woman from different angles, you can get a better idea of the details of her face and her overall appearance. And this is very much the same case when we talk about echocardiography. Multiple views can give you additional information so you get a better overall idea of how the heart is functioning. Some patients will not have adequate windows for all views, and so it's very important to be facile with all of the primary cardiac windows. This can be attributed to patients' body habitus as well as to their comorbidities. Take, for example, someone that's very thin. They may likely have very good cardiac windows, and it'll be easy for you, oftentimes, to obtain adequate views. However, if someone's quite heavy, this can sometimes be challenging. In addition, consider someone's comorbidities. If someone has a long history of COPD and has hyperinflated lungs and an increased AP diameter of the chest, it might be very difficult to obtain good cardiac views because of their anatomy. These are all factors that must be taken into consideration, and thus it makes it important to learn multiple views so that no matter the size, the shape, or the comorbidities of your patient, you'll be able to adequately answer the question you seek to with cardiac ultrasound. There are 4 principal views when learning about transthoracic echocardiography. These are the subcostal view, the parasternal long axis view, the parasternal short axis view, and the apical 4-chamber view. Before we get into the specifics of how you obtain each of those views, I want to spend a couple of minutes discussing proper orientation when performing echocardiography. Recall that for general ultrasound, the convention for the screen orientation marker is the top left of the screen. So when you look at the orientation marker when you're doing abdominal imaging, for example, the convention is to have the marker dot of the screen on the top left. In addition to the screen orientation marker, remember also that there is an orientation marker on the ultrasound probe itself. And for general ultrasound, the conventions for probe orientation is as follows. If you are going to image the patient in a long axis, the probe orientation marker should be pointing towards the patient's head. If you will be imaging the patient in a short or transverse axis, the probe orientation marker should be pointing towards the patient's right. Now, as with most conventions, there are exceptions. Procedural ultrasound is one of the exceptions to the rules that we just discussed, and also echocardiography is a notable exception to these orientations, and thus we're going to describe the proper orientation for echocardiography now. For echocardiography, the convention for the screen orientation marker is the top right of the screen, not the top left, but the top right of the screen. For probe orientation, it's a little bit more complicated. Unlike simply saying, when we're doing abdominal imaging, for example, that the probe marker dot should be towards the head or towards the right of the patient, it's not quite that straightforward when it comes to echocardiography. The probe orientation marker differs depending on what cardiac view you're trying to obtain. However, one way you can try to remember this is just remember a clock face, and that in general, if you perform the exam the way we're going to outline it today, you can just rotate the transducer in a clockwise orientation as you go from one window to the next, to the next, to the last. And if you do that, you should be able to keep it all pretty clear in your mind. So now, let's discuss the proper probe orientation when performing echocardiography. Again, there are 4 primary cardiac views that we'll be discussing today, and each of those will have a different probe orientation. The first view we will discuss is the subcostal view. For the subcostal view, you should have the orientation marker on the ultrasound transducer pointing towards the patient's left flank. The second view you will obtain is the parasternal long axis view. To obtain this view, you should point the probe orientation marker towards the patient's right shoulder. The third view is the parasternal short axis view. To obtain this view, you should rotate the transducer clockwise until the probe orientation marker is pointing towards the patient's left shoulder. Finally, we have the apical 4-chamber view. To obtain this view, you should again rotate the transducer clockwise until the probe orientation marker is pointing again towards the patient's left flank. So as you can see, going from position 1 to 2 to 3 to 4, we essentially did one complete revolution in a clockwise orientation with the marker dot. Marker dot on the probe towards the left flank for position 1, towards the right shoulder for position 2, towards the left shoulder, position 3, and then back to the left flank for position number 4. So again, just think of a clock face to try to keep that clear in your mind. Now let's talk about the subcostal view. The patient's position should be supine for this particular cardiac view. You want to place the probe in the epigastrium. The orientation marker, as previously discussed, should be to the patient's left. And you want to aim the beam towards the left shoulder. And it's important that you keep a shallow angle of approach when you're placing the transducer in the epigastrium such that you're imaging the heart and aiming up into the thorax. If you're having problems getting a good window or a good cardiac view, that can sometimes be due to bowel gas or gastric contents, fluid, air, etc. Sometimes what can be helpful is if you actually slide the transducer slightly to the patient's right, and in doing so, you can use the liver as an acoustic window. Because the liver is so vascular, it is largely filled with blood, and as a result, that is a great acoustic medium through which the sound beam can travel into the chest. Here is a video demonstrating proper technique of how to place your hand on the probe. Don't hold it from below like so, but instead I would encourage you to hold the transducer from above. In doing that, you will be able to place the probe in the epigastrium and have a shallow angle of approach such that you can focus the ultrasound beam into the chest and obtain better images of the heart. Here is an illustration that seeks to clarify the anatomy in the subcostal view. In the near field, you will notice the liver at the top of the screen, corresponding to this in the illustration. The next thing you will see will be the right ventricle, which is the most anterior chamber of the heart. Right ventricle, interventricular septum, left ventricle. Liver, right ventricle, interventricular septum, left ventricle. And then, of course, the corresponding atria, right and left atrium, right and left atrium. And here is a video clip demonstrating that same orientation and anatomy. Again, you see the liver in the near field towards the top of the screen, the right ventricle abutting the liver, the interventricular septum, followed by the left ventricle, and towards the bottom of the screen you have the right atrium and left atrium. This is a normal subcostal view of the heart. Now let's discuss the second of the 4 primary cardiac views, the parasternal long axis. This cardiac window allows for excellent views of the left atrium, left ventricle, and the outflow tract. The patient should be placed in a left lateral decubitus position, and the probe should be placed just lateral to the sternum at approximately the 4th to 5th intercostal space. The orientation marker on the probe should be to the patient's right shoulder. Sometimes it can be confusing in terms of the cardiac anatomy that you're visualizing on the screen, and if that's the case, I would encourage you to see if you can find the descending aorta. If you do, the cardiac structure that abuts the descending aorta will be the left atrium, so you can use that as a point of reference if you ever get confused. Keep that in mind. We'll discuss this further as we've moved forward in the presentation, and it'll make more sense at that point. This is the proper probe orientation when performing the parasternal long axis view. Again, you want to place the probe just lateral to the sternum with the orientation marker pointing towards the patient's right shoulder. This is an illustration demonstrating the plane that will be actually imaging the heart to give you a point of reference. For the parasternal long axis, we'll be bisecting the heart right down the middle in this type of orientation. Here's an illustration to clarify some of the anatomy. So I'd like you to start by looking here. This is the left atrium. Then the blood will flow through the mitral valve into the left ventricle chamber and out the left ventricular outflow tract through the aortic valve. Here we have left atrium, mitral valve with the chordae tendineae, the left ventricular chamber, and the left ventricular outflow tract going through the aortic valve. And here is that same anatomy. You can see a little bit of right ventricle at the top of the screen in the near field, as well as in the illustration. And here's a video clip demonstrating that same anatomy. So in the far field, towards the bottom of the screen, you have the left atrium. You can see the mitral valve opening and closing with the chordae tendineae, the left ventricular chamber, and then the left ventricular outflow tract. At the very top of the screen, you can see some of the right ventricle. Highlighted here is the descending aorta, and thus, if one was confused in terms of what cardiac structures we were examining, you would know that by identifying the descending aorta, highlighted here, that the structure just adjacent to it is the left atrium. At that point, once you know that that is the left atrium, it's rather easy to intuit what the other cardiac structures are that are currently seen on this image. Now let's focus our attention to the parasternal short axis view. This view is quite helpful to assess overall left ventricular systolic function. As you can see on the upper image on the slide, what you're looking at is a cross-section or a circumferential view of the left ventricle, so it's rather easy to assess for global contractility and function of the left ventricle with this end-on donut type of view. The patient should be placed in a left lateral decubitus position. The probe should be placed just lateral to the sternum at the 4th to 5th intercostal space, as it was for the parasternal long axis view. However, the difference here is the orientation marker should be placed towards the left shoulder, not the right. So one tip is to obtain the parasternal short axis view, simply rotate the probe marker from the right shoulder to the left shoulder. It's imperative then that you perform the exam in the order as we've discussed: subcostal view, followed by parasternal long axis view, followed by parasternal short axis view. When performing the exam in that order, to go from parasternal long to parasternal short, all one needs to do is slowly rotate the transducer clockwise so that the probe marker goes from right shoulder to left shoulder. The other positioning of the transducer on the chest wall is exactly the same. And here's what we mean. So here we have the parasternal short axis positioning of the probe on the chest, just lateral to the sternum, with the orientation marker pointing towards the patient's left shoulder. Again, It's easy to obtain once you have already done the parasternal long axis. All you need to do is rotate the probe from the right shoulder to the left shoulder. The other positioning of the probe on the chest wall is exactly the same. Rotate clockwise from right shoulder to left shoulder. And that's how you'll go back and forth between parasternal long axis to parasternal short axis. When discussing the parasternal short axis view, it's important to realize that depending on what level we're imaging the heart in the short axis, we will be examining different anatomic structures. You can change what level of the heart you're imaging by simply changing the angle of the probe on the chest wall. This is called fanning. You'll better understand this when we have the hands-on session. But for now, just realize that there are three main levels at which we can image the heart in short axis. There is the level of the aortic valve. As we change the angle of the probe towards the mid portion of the heart, we can image the parasternal short axis at the level of the mitral valve. And lastly, as we aim the transducer beam towards the apex of the heart, we can actually visualize the papillary muscle view. So essentially, the parasternal short axis has three unique views within this same orientation. Here's an illustration demonstrating the parasternal short axis view at the aortic valve level. What I'd like you to notice is there's this hyperechoic ring here, which is the outermost portion of the aortic valve, and the three cusps. That corresponds to the three cusps of the aortic valve here. This is surrounded by the left atrium, the right atrium, and the outflow tract. Left atrium, right atrium, and outflow tract. Here is a video clip demonstrating that same anatomy. What I want you to notice is in the middle of the field of view, you can see the hyperechoic aortic valve with those three cusps. In the far field, you can notice the left atrium, and just deep to that, again, you can appreciate the descending aorta if you look closely. This is a normal parasternal short axis at the level of the aortic valve. Because of the hyperechoic nature of the cusps of the aortic valve and the fact that there are three cusps, some people feel that this resembles the Mercedes-Benz logo, and so sometimes this is called the Mercedes-Benz sign, referring to the three cusps of the aortic valve. Now, let's move forward and discuss the parasternal short axis view at the mitral valve level. Here, we're looking at the left ventricle in short axis, and abutting that superiorly is the right ventricle. You can see the anterior and posterior mitral valve leaflets as they open and close, and some people feel that this opening and closing of the valves, when you're looking at it end-on in this fashion, is analogous to a mouth opening and closing. So sometimes people will refer to this as a fish mouth view, as if the mouth of a fish is opening and closing with each contraction and relaxation of the heart. Lastly, let's discuss the parasternal short axis view at the level of the apex, or the papillary muscle level. Here's an illustration better delineating the anatomy. Here we have the circumferential view of the left ventricle. Here. Adjacent to that, we have the right ventricle here and here. These are, of course, separated by the septum. This is your anterior wall of the left ventricle, and this is the inferior wall of the left ventricle. The other thing you should pay particular attention to is the papillary muscle that you can see here and here in the diagram. Here you can see it on the echocardiogram here and here. And the thing I'd like to point out is that these structures, the papillary muscle, are quite hyperechoic as compared to the other areas of endocardium. In other words, they're brighter white as compared to the other endocardium here. Here is a video clip demonstrating that same anatomy. You can see the left ventricle as it's at the level of the papillary muscle. You can see the hyperechoic bundles of papillary muscle that are all circumferentially coming together during each systole. This is an example of a normal parasternal short axis view at the level of the papillary muscle. Lastly, the fourth of the primary cardiac windows we will discuss today is the apical four-chamber view. This particular cardiac window allows for excellent views of both the left heart and the right heart structures, and this can be quite helpful when trying to evaluate for evidence of right heart strain or right ventricular dysfunction in the setting of pulmonary embolism, for example. It's also a very nice view to assess global left ventricular function. Lastly, it's an ideal view for Doppler flow assessments across the mitral valve and the tricuspid valves. This particular view can be somewhat difficult to obtain, especially based on patients' body habitus and comorbidities. So you want to be certain that you have the patient positioned properly in the left lateral decubitus position. The patient should be placed in the left lateral decubitus position. The probe should be placed at the apex of the heart. This can be found by either palpating the PMI or by simply using surface anatomy and placing the transducer at the nipple line or just inferior to the breast. The orientation marker should be pointing to the patient's left. Here are some photos demonstrating proper probe orientation. The probe should be placed on the chest wall just inferior to the nipple or inferior to the breast. The orientation marker on the probe should be towards the patient's left. When we're getting the apical four-chamber view, this illustration should help to demonstrate exactly what we'll be seeing on the ultrasound image. Remember, we're going to be placing the transducer right over the PMI, the point of maximal impulse. So essentially, we'll be placing the transducer right here. And imaging as follows in this particular orientation, going right down the middle of the heart in a long axis with the right heart structures and the left heart structures right next to each other. And that is what is demonstrated in this illustration. Here you can see apex of the heart, interventricular septum, interventricular septum. The left heart structures will be on this side of the screen if you adhere to the conventions that we've described thus far in the presentation, and the right heart structures will be on this side of the screen. So apex, left heart, right heart, separated by interventricular septum. Apex, septum, left heart structures, right heart structures. Here's a video clip demonstrating that normal orientation. Again, you'll notice anterior leaflet of mitral valve, left atrium, left ventricle, septum, right atrium, right ventricle. And again, if you ever get confused, look for the descending aorta. That descending aorta right there indicates that this structure, even if you're not certain, is indeed the left atrium. This is an example of a normal apical four-chamber view of the heart. And again, there is the descending aorta, indicating that the structure adjacent to it is the left atrium. Now, let's talk about some relevant physiology and pathophysiology to close out the presentation. Remember, a short time ago we discussed the pericardium and the fact that it's an epithelialized fibrous sac. It contains a small amount of fluid and epicardial fat that is helpful for lubrication. The sac is minimally distensible. When we speak of pericardial disease, generally we're referring to inflammation of the pericardium, which is referred to as pericarditis, or abnormal fluid collections within the pericardial sac, which are referred to as pericardial effusions. There are many causes of pericarditis. It's a very long list that goes beyond the extent of time we can take in this presentation, but suffice it to say, if we break down some of the more common causes of pericarditis into broad categories, you can break them down into infectious etiologies, collagen vascular diseases, for example, such as lupus, or also malignancies can cause pericarditis. Causes of pericardial effusion are also quite extensive. Essentially, any cause of pericarditis can lead to a pericardial effusion. Another common cause of fluid in the pericardial sac would be trauma. Ultrasound is very well suited for evaluating the pericardium. And this is largely because inflammation or trauma can lead to fluid collection in that pericardial sac. And hopefully you recall that fluid on an ultrasound evaluation looks like what? Fluid on the ultrasound will appear black, or in ultrasound terminology, it will appear anechoic, free of echoes. On the left side of the screen, you will see a normal subcostal view of the heart with no pericardial effusion. The image on the right is also a subcostal view of the heart. However, as you can see here outlined in red, you will note there is a pericardial effusion that completely envelops the heart. And you'll notice that by the detection of an anechoic stripe of fluid that covers the anterior and posterior aspects of the heart in this view. Recall, fluid is black or anechoic on the ultrasound, so any significant anechoic signal surrounding the heart in any of the views is concerning for pericardial effusion. Normal is on the left, pericardial effusion is noted on the image on the right. Now, let's talk about assessing left ventricular systolic function. Ejection fraction is defined as the percentage of blood ejected from the ventricle during systole. There are quantitative and qualitative measures to assess the ejection fraction. Normal ejection fraction is greater than 50%. Moderately depressed ejection fraction is on the order of 30 to 50%. Severely depressed ejection fraction would be anything less than 30%. To qualitatively estimate ejection fraction, I'd like you to do two things. Watch for symmetric and robust movement of the endocardium, which is the part of the left ventricular chamber that's highlighted here. I also want you to pay particular attention to the excursion of the anterior leaflet of the mitral valve in the parasternal long axis view. The valve excursion should come up and almost touch the interventricular septum as it opens. Ideally, you want to view the left ventricle in two planes for this qualitative assessment. The parasternal long axis and parasternal short axis, for example, or also the parasternal long axis and the apical forechamber are two other ideal views to assess systolic function of the left ventricle. So let's take a look at normal. Here, I'd like you to take a look at this septal portion and inferior wall of the left ventricle. And you can see during each systole, the myocardium appears to be thickening, and there's good, robust, symmetric movement and contraction of both of these aspects of the left ventricular wall. So that looks good. In addition, I'd like you to look at this anterior leaflet of the mitral valve. And as this valve opens, it's coming up and almost coming into contact with that interventricular septum there. That's indicative of good filling and of good squeeze. So this is grossly normal ejection fraction. Here we have an apical forechamber view. And again, you can see the anterior leaflet of mitral valve coming up and almost hitting the septum. In fact, it is in this view. So that is indicative of good function. And in addition, you can take a look at the left ventricle. Here we have the septum that appears to be having good contractility. And we also have this lateral wall that appears to have good, robust contraction as well during each systole. Now let's look at these abnormal examples. Let's go through the same process. If we look at this parasternal long axis view, we can look at the endocardium of the left ventricle. And here perhaps the contractility seems all right. However, if we look at the inferior aspect of this left ventricular chamber here, the motility is very poor, and this hypokinesis is suspicious for an abnormal ejection fraction. If we take it to the next step, we can look at this anterior leaflet of the mitral valve right here. And in general, remember, we said when it opens, it should come up and almost touch the interventricular septum. And here, it's not even coming close. So the fact that we have decreased mitral valve excursion and decreased motility of this inferior aspect of the left ventricular wall, those two combine to tell me that this is abnormal systolic function. In other words, a decreased ejection fraction. Now let's look at another patient. This is an off-axis apical view. So instead of the septum coming straight up and down, it's somewhat off at an angle, but nonetheless, it's still a helpful view. These are the right heart structures. This is the left heart structures. This happens to be the outflow tract. As you can see, the anterior leaflet of the mitral valve is not moving very robustly at all and is not coming anywhere near the septum. In addition, if we look at the septal portion of the left ventricle, it's hardly contracting at all. So we have hypokinesis here and along this lateral wall as well. Very poor contractility. So poor contractility here, poor contractility here, poor mitral valve excursion. All of this combined tells me there is very abnormal or very decreased systolic function and decreased ejection fraction in this particular patient. Now let's go on to the last topic of the presentation, and that is assessment of valvular function. Recall that using the Doppler mode on the ultrasound system allows for assessment of direction and velocity of blood flow. Directionality is revealed by the color flow map, which is what you see here on the far right of the ultrasound image. The top of the color flow map is the color of the flow towards the probe. So you can just remember that top of the map is towards the probe. Oftentimes, the color map will have red on top and blue on the bottom, and when it does, you can use a mnemonic BART. Blue is flow away from the transducer, red is flow towards the transducer. On occasion, the color map will be in a different orientation such that blue is on top and red is on the bottom, in which case the BART mnemonic won't apply. But in general, if you just remember that the top is towards, then you'll be in good standing and have the correct orientation in your mind. The use of color flow Doppler in echocardiography is a sophisticated tool that allows us to assess cardiac valve function. Specifically, we can look for regurgitation and stenosis. Grading regurgitation and stenosis requires specialty training and expertise and is generally done by cardiologists. In fact, there are some cardiologists that take special interest in echocardiography and they obtain additional training to gain even more expertise in this area. In general, however, the grading scale for regurgitation and stenosis is simply mild, moderate, and severe. As an example, let's look at the assessment for mitral regurgitation. To perform this assessment, we would like you to obtain an apical 4-chamber view, as you can see in the top of the screen, and then activate color Doppler mode, as you can see in the bottom. Now, why do you think we use the apical 4-chamber view? Think about it for just a moment, and think about the physics of how the Doppler signal works. Remember, the probe position is right at the apex of the heart, and the flow through the mitral valve is going to head directly towards the transducer, and thus it'll be a very robust signal in terms of the color Doppler because the flow is heading directly towards the transducer and will thus allow us to get a perfect vantage point to assess for proper versus improper flow across that valve. So while in the color Doppler mode, you're going to want to position the color flow box such that it includes the entire flow jet on both sides of the valve. So, when assessing the mitral valve, we want to make sure that the color flow box should include the entire left atrium, the mitral valve, and the basal segment of the left ventricle. So in other words, our color flow box should be approximately this size and incorporate all of the left atrium, all of the ventricle, and the basal segment of the left ventricle as well. And this you can see illustrated just like so. Let's take the example of the mitral valve without mitral regurgitation. Red flow is towards the probe during diastole. In other words, during diastolic filling, when these valves are open, blood should be flowing from the left atrium right into the left ventricular chamber, from the far field into the near field, from the far field into the near field. Now remember, the cardiac transducer, the probe, is right here, and thus if our vantage point is here, that blood flow is going from left atrium to left ventricle. It's heading right towards the transducer, and thus we should get a very robust orange and red coloration of blood flow towards the transducer. That's what we expect during diastolic filling of the left ventricle. There should not be any blue flow or flow away from the probe into the left atrium during systole. During systole, you'll see the valves close. When they close, there should be no regurgitant flow in the left atrium. If there is regurgitant flow in the left atrium, when the valves are closed, you'll get some blue signal or flow away from the transducer. We don't see that here. This is a normal condition. Now, you will note some blue signal in the left ventricle itself, but that is okay. That can be attributed largely to two things. Either turbulence of flow in the left ventricle. As these valves are opening and closing, there will be some inherent turbulent flow adjacent to it. And also, some of this blood in the left ventricle is supposed to exit out the left ventricular outflow tract. And in doing so, it will, of course, be heading away from the transducer. Thus, you will get some blue signal. However, that'll be blue signal in the left ventricle, not the left atrium. Now, let's compare normal to abnormal. All right? Pay particular attention to their corresponding atria. So again, with each diastole, as the valves open, you're getting a very robust red flow in the left ventricular chamber, which with each systole, as the mitral valve closes, we look in the left atrium and we're getting no blue flow or no flow away from the transducer when these valves are closing. Thus, there's no regurgitant flow in the left atrium when these valve leaflets are closed. That's the normal condition. Contrast that with severe mitral regurgitation. If we look at this here, again, this is left atrium, this is left ventricle. As this valve opens, we're seeing red flow in the ventricle. Okay, that checks out all right. We're seeing some blue flow in the left ventricle, and we talked about that potentially being okay as well. However, when this valve leaflet closed, we should not see any green and blue coloration of flow away from the transducer in the left atrium, and in fact we do. So for all of systole, when this left ventricle is contracting, there is regurgitant flow throughout all of systole in this left atrium, resulting in green to blue coloration of flow away from the transducer. So pay particular attention and look at the left atrium here with no blue coloration during systole, and contrast that with the left atrium in the heart with severe MR. Here we can see some green and blue flow throughout all of systole, and that indicates severe mitral regurgitation. Now, let's wrap up with a few key points and conclusions. In my opinion, echocardiography is amongst the most challenging point-of-care ultrasound exam that you will perform, and so I would encourage you not to get frustrated or upset if initially you're having a hard time trying to remember the orientation or having a hard time getting proper cardiac views yourself when you practice on each other during the hands-on session. However, there are some things you can do to help decrease the risk of this inevitable frustration, and that is patient positioning is really important for the reasons we talked about. Essentially, you want to have the patient in a left lateral decubitus position for all of the cardiac views with the exception of the subcostal view. Remember, there are four principal cardiac views: the subcostal, the parasternal long axis, parasternal short axis, and the apical four chamber. The orientation for the probe and the screen are unique for each cardiac view, and initially this can be somewhat daunting and difficult to remember, but just recall that if you just remember the clock face orientation and start by performing your exam with the subcostal view with the orientation marker pointed towards the patient's left and then sweep in a clockwise fashion, you should be okay. With practice, you will become proficient, and this really is one of the most important point-of-care ultrasound exams you can do. It's incredibly helpful as a clinician, and you'll find it well worth your time to learn this modality. I'd like to acknowledge some people that helped me with this presentation. Dr. Virag Shah and Dr. Andrew Khan were invaluable for helping me with obtaining video clips, some of the photos and the videos that were done to demonstrate the proper positioning, as well as technical assistance on the nuances of valvular assessment. I'd also like to thank Cody Saxton, who assisted me and provided many of the original medical illustrations in this presentation. Here are some references used for this module. And I'd like to thank you very much for your attention, and I look forward to scanning with you all in the hands-on sessions to come. Thank you so much.